Hello, Ruth Myers here. Thank you for attending. This seminar is going to look at some basic everyday ways to help that can be considered in association with a person's genetic syndrome diagnosis. One of the great things about the status of science and observation and people telling about their lives these days is that sometimes we can learn things that are very specific to a given syndrome that can be helpful for that person. Think about some of the people you know. Do they have a genetic syndrome? Have they been diagnosed with a particular syndrome? Does it matter in terms of their everyday support? We'll talk about some fairly common syndromes, and we'll talk about some very rare conditions that illustrate points that are not only particular to that syndrome, but particular other similar syndromes may benefit from a similar approach and strategy. The ones we're going to summarize very, very quickly today, it's kind of a list, and you see the list is in very small print. We will not be making any kind of exhaustive encyclopedic review of all of these syndromes. Each one of these syndromes is at least 2 or 3 careers of 2 or 3 geneticists and textbooks and articles and everything else. These are just some very, very brief ideas to consider if you have the opportunity to provide support to a person who's diagnosed with these different syndromes. A couple of research materials. I think this is absolutely a fascinating book. Was edited by my dear, dear friend Dorothy Griffiths, who is long-term superstar brilliant in the field of behavior analysis. And as you can see, it was published in Canada because it's behavior, not just behavior. And it has a lot of really good, thorough, detailed descriptions of some of the additional medical and neuropsychiatric issues and what it might mean in terms of behavior support. Also, I was told by somebody I kind of respect a lot that I have to kind of mention the book that we wrote, Steve and I wrote, and it's pertinent here. I know, doesn't he look great? Wouldn't you buy a book from this man? There are chapters in the book that expand on some of the things that we'll be talking about here in this discussion. Probably the most important thing, though, to say after I've just shown you recommended books is that most of what's published about how well people can do lags behind reality by at least 10 years. So if you read an article today that says that people with Chidiac-Higachi thyroiditis only live to be a certain number of years, don't be too swayed by that. Don't be influenced by that. Because in fact, as the things are being published, people are doing better than anybody said they could. So I believe that's one of the really, really central reasons why almost every syndrome has a self-advocate, family advocate website or other source of information. Sure, what I tell you about tuberous sclerosis may be useful, but the Tuberous Sclerosis Association of the United States is going to be up to the minute, not just up to the week. So very useful, good to have. You know, some other stories, you're welcome to borrow them if you like. The University of Cincinnati College of Medicine, Division of Developmental Medicine, developed a visiting program 40 years ago, where as soon as a baby was born that was observed to have a genetic syndrome, so a baby might be born with Down syndrome or some other recognizable genetic syndrome, a happy, healthy adult with that syndrome would go visit the family. which when I was going to school there and I observed it, I thought, well, that just makes all the sense in the world. Unfortunately, it's still standard practice for the whole system to treat the birth of a child with a syndrome as some kind of tragedy, which is a big burden to heap on a little baby, isn't it? As much as we can, the people that are supposedly trying to be helpful people to the people we support, as much as we can stay away from that kind of approach, the better people are going to do. I don't know if the University of Cincinnati still does that, but it was a very, very popular program. And sometimes those visitors, the visitors with Williams syndrome or Prader-Willi syndrome or Down syndrome or whatever recognizable genetic syndrome, those happy, healthy adults would visit that baby right at their birth, and sometimes they'd stay friends for years and years and years. It was mentoring, it was encouragement. It was a much better response than treating it like some kind of disaster. Dick Simons, who is like the most psychoanalyst you ever met in your entire life. This guy would sit in grand rounds. By the way, I'm talking now about the University of Colorado Department of Psychiatry. And it's a very, very psychoanalytic program in those days when I was on faculty there. And you know how psychoanalysts are, right? These Freudian guys. He hadn't had a facial expression in 50 years. I'm quite sure of it. Right, he'd sit in the audience, and I was doing my thing as junior faculty, right? You know, and junior faculty, you got to give a presentation to the rest of the faculty, trying to show your scientific data, but sort of in a way to kind of prove that you belong there, right? Kind of a deal. And there's Dick Simons sitting where he always sat, because if he moved chairs, it might disrupt the psychoanalysis of some of the other faculty sitting in the room, right? Whatever. So he's sitting there, no facial expression. I do my shtick, talk about, think about people in terms of their strengths and their qualities and their resilience, and don't get so caught up on supposed deficits, blah, blah, blah. I'm going on and on. Dick Simons, no expression. I finish my thing, and then he raises his hand like anybody's not going to call on him. And he says the thing he always says. Well, thank you for a very interesting and stimulating presentation. I'm like, great, you say that to everybody. And then he started to say more, which kind of got everybody's attention. He said, part of the reason I liked your presentation, Ruth, is that one of the reasons that I am a success today is because of my aunt with Down syndrome who raised me. The most brilliant guy in the department. All of a sudden, everything I had to say had some value. And then Al Ahrensdorf was a stupendous pediatrician, practiced in Hawaii for probably 70 years. When he was in high school, he said, he didn't think much of it at the time, but he probably should have. The valedictorian at his high school was a person with Down syndrome. Imagine that era. For somebody with Down syndrome to be the best student in the whole school, not special ed. These are real stories. And sometimes those give people hope. And why shouldn't we emphasize that? As long as we celebrate everything a person does well and don't say to them, well, you could be, Dick Simons' aunt, As long as we're not doing that to people, but we're saying, yeah, there's reason for optimism. If you're happy where you are, that's great too. We're all in. We love you exactly how you are. But we also know the sky's the limit if you want to do something else. So what's useful about knowing if a person has a genetic syndrome or a metabolic syndrome or what have you? Well, the big thing is anticipating medical risk, right? We know, for example, if you have Fragile X syndrome, we should be looking at your heart a lot earlier than we do in the general population. Endocrine issues, hormone issues having to do with your thyroid, for example, if you happen to have Down syndrome. There's lots and lots of really good literature on improving the healthcare of people with Down syndrome, and it's all about checking for stuff earlier. Now, does it make a difference? If we're a little bit more medically diligent, does it make a difference? Well, the year I was born, the life expectancy for a person with Down syndrome was 21 years. Now the life expectancy of a person with Down syndrome is about 69 years. And the only difference is better health care. Medication support, certain medicines work better for certain people. We do things quite a bit differently, for example, to support people with Smith-Magenis syndrome than we do for just about everybody else with sleep problems, based on the specific, unique physiology that goes with Smith-Magenis syndrome. Non-medication support, this is of extreme importance, isn't it? We all know the sensory issues of our friends and neighbors with autism, Fragile X, Klinefelter syndrome, Noonan's, Turner's, all of those conditions. Communication can be a little different, and we'll have some specific examples here in a couple minutes. Empathy. Does it help if you understand better what a person's going through? Yeah, I think so. Right? What did we say is the most important factor in people having successful, happy lives? People who believe in me. You can believe in a person a lot more when you understand what's going on, right? And informed behavior support. And that's part of what I like about Dorothy's book, is that it talks about how certain sort of superficial behavior analytic approaches to people are just misguided. They won't help. But if we can adjust what we offer people based on their unique genetic physiologic needs, that person is going to benefit. What's the drawback? Well, there's a lot of drawbacks, aren't there, to any kind of pasting of labels on people. Stereotyping, big deal. I have a special fondness for people with Down syndrome because the stereotyping that people with Down syndrome have endured over the years is just ridiculous. Yet people still go about living their unique lives of people with Down syndrome. Anybody remember the day when they used to say, everybody with Down syndrome is such a sweetheart? Remember those? Fabulous to get in a room with about 100 parents of people with Down syndrome and say, did you know that all of your kids are happy and delightful and peaceful and fun all the time? Yeah, quite a reaction there. And it's even one step further, because you know what I'm going to say. If people's friend, sibling, child, employer doesn't conform to some stereotype, the people providing service think they're doing something wrong, but they're not. What's that they say? If you've met one person with autism, you've met one person with autism, right? Inappropriately low expectations, I think this is a systemic issue that we all struggle with everybody. But it's particularly so if people get too caught up in some of the prognostic statements made in some of the textbooks. Cookbook approaches are a problem. It's one thing to say these are ideas you might consider offering to a person with Fragile X syndrome. It's quite another thing when somebody says, this is the list of all the things you need to do to or with that person with Fragile X syndrome, whether they like it or not. That's kind of a cookbook approach. It's prescriptive and it tends to not produce the best outcomes, does it? Everybody's different, right? I think that the other problem, and we have to face the fact that it's occurring to this day, which is genocide. There's probably a better term for it, but I can't think of one. The most recent example of a countrywide genocide is in Iceland, where all of the people who were pregnant were required to have amniocentesis. And if the amniocentesis showed the presence of Down syndrome, they were required to have an abortion. And that is still going on. How can that be legal? And of course, we know it's not moral. And just between you and me, I don't know why you'd ever want to eliminate people with Down syndrome from the world. I mean, there's a whole heap of people that I'd rather have fewer of them and way more people with Down syndrome. But that's my bias. People should be able to make their own personal decision, of course. But having a governmental mandate to kill all the babies with Down syndrome doesn't make sense, does it? Yeah, it's wrong on so many levels. Discrimination obviously is an issue. I've seen a number of times where a person, for example, a person with genetic syndrome that is supposed to impair certain qualities, person will take the objective test, qualify for whatever it is they're wanting to do, whether it's a course of study or a technical school, but not be allowed because of their syndrome. Well, people with your syndrome can't do that. Well, on the test I did, and having to really fight for the same opportunity for which they are qualified. Diagnostic overshadowing. And carnival behavior. Have you all seen this? Person has a particular exceptional skill related to their genetics, and other people always want them to show it. Here, dance. Now, some people enjoy showing off. That's great. I love it when people are proud and like to show off. That's not what I'm talking about, though. Carnival behavior is so objectifying. Obviously, the other thing that I think is terribly important, and it falls under the heading of genocide being a problem, is that I don't think it's reasonable, correct, or even sensible to ask people to get tested for a genetic syndrome because it's your goal for them to not reproduce. I'm not going to say to somebody, I'm going to test you for your genetic syndrome to see if you're going to, pass it on. As if that's a bad thing. Now, I have known people that will test for syndromes because they just want to be ready. Oh, if my baby's going to have Williams syndrome or Smith-Magenis syndrome or Fragile X syndrome, oh, I got some planning to do. Okay, that's a different story. But somebody who's basically being given the idea that we're doing all this testing because we don't want any more of you, how does that help? It doesn't help anybody, does it? So let's talk about some syndromes. The most common sort of basic textbooks in this area are Smith by Jones. It's an old book, keeps getting revised. It shows the exact physical characteristics in a lot of pictures, people with different genetic syndromes. Also offers a framework for understanding, what are the implications of a midline syndrome. If a person has unusual features here, they may have unusual features all the way through the center of their body that may or may not be readily apparent until the person grows. And then the APA published a textbook of pediatric neuropsychiatry and neuropsychiatry in the community that have chapters by me talking about neuropsychiatric aspects in adults with various genetic syndromes. Once again, I would not say it's stupendous writing or anything like that, but I do have a lot of references in there and a lot of other places to get even more information as you try and learn more and more to help people. So there was this guy named Kim, sweetest guy you ever met in your life, but we were being asked to evaluate him for explosive violence and anger episodes. And no socialization, no interest in socialization, no interest in communication, absolutely resists everything. I thought, wow, that's a lot. And furthermore, and then this started to get me going, and furthermore, his family is here under questionable circumstances. Oh my, what's that about? Well, we get to his house to go visit with him. This is in a state on the East Coast. And his auntie greets us at the door, his beloved auntie. She's there as an interpreter because the family speaks mostly Vietnamese, some English, and she's quite fluent in both. And she says, Kim has locked himself away in anticipation of our visit. Well, what's that about? Oh, no. He doesn't not want you here. I said, yeah, because we're not going to force ourselves on anybody, right? And she said, no, he's just afraid he'll lose control. That doesn't sound like somebody who doesn't care, does it? It does sound like somebody who's having a very hard time keeping control. So I go up to the bedroom door. My consultation partner goes to meet with the rest of the group, and I start telling horrible jokes to his bedroom. I mean, really groaner, bad dad jokes, right? And I start to hear laughter. And then he finally laughs, and he comes out, and right in front of my eyes, now this is a guy who had been to 5 different neurologists, 4 different psychiatrists, in a state where they have like tons of really, really, really sophisticated care. I don't know how they missed this, but his face showed the absolutely classic, no question about it, changes that you see in people with tuberous sclerosis. Well, I thought that's kind of important. We go downstairs to visit with the rest of the circle. And before I start asking him questions, because even though he supposedly doesn't speak, am I still going to ask him questions? Of course I am. Maybe he'll respond. Maybe he'll tell me to go away. And after the first question, he held up a finger, looked around, took a tablet of paper. He wrote down my questions in English and in Vietnamese, then wrote down his answers in English and in Vietnamese, so the Vietnamese-speaking members of the family could understand. What? Why were they saying these appalling things about him and his family? They could not have been any more gracious. Well, the same people that had kind of dismissed him as bad and violent from a questionable family had said that all his imaging studies were unremarkable. Which is not to say normal, is it? So I did the thing we've talked about in other seminars. I said I must have the radiologist's report, not just somebody else's summary. The radiologist's report showed, and you'll not be surprised like this, that he had tuberous type tumors in his brain, 1 in each temporal lobe, which is probably the reason for the violent temporal lobe seizures, and probably the reason why he could write fluently but couldn't make the words come out vocally. So, really long story short, he finally got treated by a tuberous sclerosis expert. The seizures went away, and it came to a point where he was able to speak as well as he could write. Tuberous sclerosis is a condition where people grow these non-cancerous tumors anywhere in the body and can affect any structure in the body, which is why the Tuberous Sclerosis Association has created a very thorough document of surveillance. These are the things you should be checking every year. These are the things you should check every other year in terms of heart, kidneys, lungs, and pretty much every structure of the body, especially the brain. These tumors, even if they're benign, can interfere with brain flow. They can interfere with herd function, which should be heart function on this slide, and kidney function. And occasionally these tumors turn cancerous, which is another reason to watch for them. And this is a picture of a way the skin can look in a person with very classic tuberous sclerosis. And this is a publicly available picture. So what are everyday ways to help? If we're providing support to somebody with tuberous sclerosis, what are the ways to help? Well, the big thing is to be vigilant for pain. New pain can come out of nowhere, and it can happen frequently. And it is almost always because a tuber is gotten in the way of something. Seizure control is an essential aspect. Almost everybody with tuberous sclerosis has difficult to control temporal lobe epilepsy or some version of that. And it's all related to the anatomical challenges and the chemical changes. Heart function is a big deal because tubers can grow in the heart and obstruct valves or otherwise interfere with the ability of the heart to pump. Kidney function is another similar area. And every time there's a change, this person's having more seizures, this person has a new type of pain, she's short of breath, her ankle started to swell, whatever. Anytime anything like that happens, the entire system needs to be looked at again. That is the correct way to proceed. We are tried to, in our mobile crisis unit, worked with somebody with tuberous sclerosis who had not had any proper monitoring in 22 years. 22 years. And she has symptoms related to illness in every part of her body, and she still tries to be sweet and charming. Extraordinary in context. But we're going to get her involved with people that are experts in tuberous sclerosis at UCSF, and I'm very hopeful. Because as strong as she is to get this far, with the right kind of help, she'll be unstoppable. Cornelia de Lange syndrome is a very interesting condition because there are so many things that a person is at risk for, and most of the people I know with de Lange syndrome have issues in more than one part of their body. And management of those makes an enormous difference in terms of a person's health and well-being. The other name for it is Brockman-de Lange syndrome. These are some of the physical features that you can see on here. Some of the real strongly characteristic signs are the anterior hairline by the forehead coming to a bit of a widow's peak, hairline a little bit low, really thick eyebrows, sometimes meeting in the middle, tiny hands and feet, usually for the most part, and some subtle, or not very subtle, skeletal distortions to where one side or part of one side of the body is smaller than the other. This can be strongly associated with unusual heart structures, such as tetralogy of Fallot, hypoplastic aorta, which is, the big gigantic pump that comes out of the heart and supplies the body. If that one is squeezed down, it makes it very hard for the body to function. It's hard to get the blood there. And certain other unusual vascular changes. Some of them are not really obvious until the person starts to grow. And these are some of the textbook pictures of little ones with Cornelia de Lange, and you see the sort of the wedge shape of the infants that doesn't persist into adulthood, but it's one of the clues in childhood. And these are some close-ups of faces of people with Cornelia de Lange syndrome. You see the very characteristic eyebrows, little mouth, low anterior hairline. So what are some issues that might be pertinent in terms of helping people with Cornelia de Lange syndrome? People have strength in visual spatial memory and perceptual organization. So where stuff is and how a place is arranged is very important. and shouldn't be altered without the person's input. Usually people have tiny little ears, and hearing can be kind of intermittent because it's easy for that all to get blocked off. It's speculated to be part of the asymmetry of the spinal structures, but in fact, people with DeLange syndrome often have a lot of pain in their bodies that is otherwise hard to explain, but deserves treatment. There's a much higher risk of genital malignancies. So if a person has, for example, irregular menstrual periods or extreme pain or no pain or unusual structure of the testicles or what have you, we should be pushing hard for that person to get evaluated for the possibility of tumors, even if they otherwise don't seem to be at risk, according to the general population. There's a much higher risk of reflux, other unusual structures in the gastrointestinal tract. We have one gal we're supporting with Cornelia DeLange syndrome that has all of this and has actually an ileostomy as a result. But we're hopeful that can all be reattached. With just a little bit of revision, she can have a lot more comfort. And sometimes little ones, infants and children with DeLange syndrome, benefit from receiving supplementation with growth hormone, but it's not absolutely necessary by any means. So what else? Well, people with DeLange syndrome may have self-injury as an activity, and it's almost always because they're in pain, not necessarily for other reasons. People with DeLange syndrome have elevated sensitivity to touch, and in fact are sometimes misdiagnosed as having autism, even when they don't. Eating and sleeping and all those other activities are often quite naturally irregular. There's mood changes, and there's no consistent chromosomal finding, but there is sometimes an abnormality of chromosome 3, but that's not a diagnostic test by any means. People with DeLange syndrome are at grave risk if anybody tries to put them in restraints. This little boy with DeLange syndrome was put into a restraint in a seclusion room and was killed. And as you can see, he doesn't look all that dangerous. Yet the school was so focused on compliance that that's what they did to him. Cornelia DeLange syndrome is one of many absolute contraindications to any form of manual restraint, and he illustrates some of the reasons why. Rubinstein-Taybi syndrome. Now, I went to medical school at the University of Cincinnati, and the main guy for the developmental medicine division was a guy named Jack Rubinstein. Yup, the guy who first recognized Rubinstein-Taybi syndrome. So you can bet your buns that we learned about Rubinstein-Taybi syndrome at the University of Cincinnati. Interesting condition because the physiology of it alters how we support a person if they develop certain conditions like anxiety disorders. People with Rubinstein-Taybi have a very characteristic set of facial features and very characteristic thumbs and large toes. This is the gal I worked with for many years with Rubinstein-Taybi. She has the absolute classic face, and she's happy with everybody knowing. This is her thumb. People with Rubinstein-Taybi have this unusual broad thumb. These are some baby pictures from the textbooks on Rubinstein-Taybi syndrome. And as you can see, very subtle, but still significant facial features. The features become more prominent as people age, particularly this really cool nose. Often the cool nose gets very long and sometimes even tilts to one side. Very fascinating nose growth pattern in people with Rubinstein-Taybi syndrome. Well, what are some ways to help if we are working with somebody with this condition? Well, the first thing is to be aware that there's a high likelihood of ventricular septal defect or patent ductus arteriosus. Rolls right off the tongue. Those are heart problems that can cause people a lot of mischief as they age. So if a person is telling you they feel like they have palpitations or they're breathless or something of that nature, really good idea to say to the cardiologist, I'm concerned about the cardiac manifestations of Rubinstein-Taybi syndrome that this person has. And a good cardiologist will either know it already or look it up. People with Rubinstein-Taybi are highly vulnerable to lung infections. They often have unusual patterns on the EEG. And here's the thing, if they have anxiety disorders, if they are treated with medicine, it's much better to use anti-epileptic medication than it is to use typical anti-anxiety medication. That's just one of the particular characteristics of people with Rubinstein-Taybi syndrome. Turner syndrome, we don't necessarily see too many people with Turner syndrome in the intellectual disabilities world because most people with Turner syndrome have fairly average IQ scores, if not gifted. The thing that's interesting is that if people with Turner syndrome do not elect to have hormone supplementation, they're a lot like people with Prader-Willi syndrome in terms of their growth and their life is better, their health is better, if they receive some hormone supplementation as they age. Sex hormones typically, sometimes some growth hormone as well. Has to do with muscle strength, has to do with processing nutrients, has to do with exercise tolerance and maintaining a weight that's comfortable for that given individual. There's also a higher likelihood of certain complications later, like Crohn's disease or ulcerative colitis, and unusual forms of thyroid. So these are people that have, instead of the usual number of chromosomes, they have one less, so they have an X chromosome and they are missing the second sex chromosome, 45XO. And these are some pictures of a girl growing with Turner syndrome. This is somebody who obviously did not receive treatment because she has that wedge-shaped body and no characteristics, no growth characteristics when she ordinarily would otherwise. So what else is important? Well, people with Turner syndrome or versions of it are often more gifted in terms of speech than they are in terms of visual processing, seeing what's around them, logging in what it means. And they tend to do better in terms of speech than they do in terms of numbers. The issue, maybe an issue, is that sometimes people will notice how gifted the person is in terms of speaking and think they're just not trying very hard when it comes to the stuff that's harder. It's important to keep in mind that just because they got this gift here doesn't mean they don't need a little help over here. But particularly when people are able to speak well, the tendency to overestimate what's easy for them is an issue. Noonan's syndrome is a condition where people have the same chromosomes, but they have a male body type. And people with Noonan's syndrome also tend to thrive and do better if they have supplementation with sex hormones. And these are some of the textbook pictures of little boys with Noonan's syndrome. The next condition doesn't have a genetic marker, but it has a biochemical marker. So you can test this with blood tests. It's called Smith-Lemli-Opitz syndrome. And we are Right now at STEP, we have 2 people with this condition, one that was diagnosed a couple years ago and one that just got diagnosed. Now, this is a fascinating condition because of how much it stirs up in the general medical public or the public at large. This is a condition where people don't make enough cholesterol to meet their body's needs, and when their body still is craving the cholesterol they need, so they build up the precursor molecules. You probably remember the way cholesterol is created. You get a bunch of building blocks, and then you put a bunch of enzymes on them, and they get to be this and this and this and this, and then they are almost cholesterol. It's called 7-dehydrocholesterol. And they need one more enzyme to turn it into proper pure cholesterol, because cholesterol is kind of an important component of like every cell in your body, right? Especially important for brain cells, nerve cells, and immune function. The old idea you hear from some people that you can't have too low of a serum cholesterol level. It's not true. If you get below a certain amount of cholesterol in your body, and it's not enough to meet the needs for all your brain cells and your immune system cells and so on, you end up with some pretty severe complications. Brain problems, if this starts to happen before you're born, because you got Smith-Lemli-Opitz syndrome, you'll often get unusual physical features, but they're not always extremely pronounced. But the thing that happens is that if it never gets treated, people with Smith-Lemli-Opitz syndrome mostly behave like a person with their brain on fire every day. Hallucinations, mood swings, aggression, explosiveness. On top of that, their ability to think and learn is markedly suppressed. So they end up appearing to have much less cognitive ability than they probably have. And then on top of that, their immune systems don't function very well. So they get sick with every single thing that comes along. Now, this is the part that is pretty much a felony in some states. The treatment of Smith-Lemli-Opitz syndrome, are you ready? The person needs to drink a certain amount of pure cholesterol every day. It's not as easy as it sounds to get pure cholesterol. You'll hear people saying, well, if you need to bump up your cholesterol, just eat foods with a lot of fat in them. Well, that's not how it works, right? If the person could make the cholesterol out of all these other fats, they wouldn't have the problem. So if a person starts eating 3 dozen eggs a day and 2 pounds of butter, they'll still bunch up all these building blocks for cholesterol, but then they'll still get stopped at the point where they're missing the enzyme to make it into pure cholesterol. So in fact, we have to go to a very special compounding pharmacy for the people to get the pure cholesterol to eat. It doesn't make a difference. I mean, that's a really good question. So, okay, they need pure cholesterol to help repair their nerve cells and their immune system. Does it make a difference? Well, for one of the people served by STEP who is spending 10 hours a day in restraints and receiving nearly general anesthesia levels of psychotropic medications, I think it made a difference to him because now he's been free of any form of coercion and he's on practically no medicine. And he's happy, healthy, athletic, and successful, and has been that way for almost 6 years after starting cholesterol. And you all know who I'm talking about. Nobody remembers when he was spending 10 hours a day being tied up in restraints. Just took the one test to figure it out. Treatment with high-dose cholesterol, 200 milligrams per kilogram of body weight per day. And the immune system is one of the most important parts of the person's body and health that improves as well. And this man, the one I just mentioned, hasn't been sick with anything in all the time since he started taking the cholesterol supplements. Smith-Magenis syndrome. I'm pretty sure we have a few people at STEP that have this. We just haven't found them yet with chromosome testing. It's an interesting condition because of the way it flip-flops a person's natural sleep cycle. There's a whole bunch of specific physical features. People often have kind of a hoarse, rough, deep voice. They have a tendency to have extreme self-injury, and they have a tendency to always stay up all night. And for a long time, it was just a puzzle. It was just a vexing puzzle. But then it turned out that the reason for that was that people with Smith-Magenis make all their melatonin, the sleep chemical, in daylight. And they don't make any at night. So some people suggest, well, why do we fight that? Why not just live your life with a flip schedule? And some people do indeed elect that pattern. Okay, you will sleep all day and be up all night. That's your life if you want it. The chronic sleep deprivation, though, from the flipped cycle and so on, seems to contribute to a tendency towards depression and self-injury. Well, now this is what's interesting, is that, those blood pressure medicines, beta blockers, that I tend to say unkind things about? Well, one of the reasons beta blockers mess up people's sleep is that over time, they suppress the production of melatonin. So now people with Smith-Magenis who'd rather be awake during the day and sleep at night get on a protocol of taking beta blockers during the day and then taking whopping doses of melatonin at night. And that can sometimes be enough to flip them back into a cycle that's more consistent with the lifestyle they want. Very interesting. Yet if people hadn't studied, how would you know? You'd certainly never stumble on that by accident. It's a picture of a very happy person with Smith-Magenis syndrome who is on the protocol I just mentioned. This is a publicly available picture. Smith-Magenis syndrome has a wonderful family foundation, like pretty much all these other conditions we're talking about. XXY Klinefelter syndrome, so 47XXY, is a condition that has the distinction of being one of the very first genetic syndromes that had a phenotypical feature assigned to it. What do I mean by that? There was one specific behavior that occurred much more often in people with Klinefelters than in anybody else, people without Klinefelters. Any of you remember what that is? Think about that for a minute. It was, because it's on here, you already saw it, fire setting. And it's still a thing. If a person has Klinefelter syndrome, that's one of the things that they are much more likely to be drawn to than other people. So it's something to watch out for. Not everybody with Klinefelters wants to burn the house down or anything, but it could be, it's a more likely tendency if people have that genetic structure. These are just some, again, textbook pictures of people with Klinefelters, some tall stature, what are felt to be unusually small genitalia, and people sometimes get some benefit out of taking some testosterone as a way to improve muscle strength, mood stability, and exercise endurance. Williams syndrome is another very interesting condition because of the communication issues involved. People have a very characteristic appearance, small, low-set ears, depressed nasal bridge, short sides of their eyes, often a thick, heavy mouth, and an unusual sort of deep metallic vocal tone. They tend to be on the thin side, and over time, unless they're very careful, they end up with troubles with lots and lots of kidney stones and even possible damage to the kidneys. And these are some of the textbook pictures of little kids with Williams syndrome. And this is Steven Tyler from Aerosmith, and I'm pretty sure he's got Williams syndrome. So I wrote to him and said, I think you got Williams syndrome. Would you send me a few tubes of your blood? You know what? He never responded. Can you believe it? Well, the other thing that's kind of cool about people with Williams syndrome is that they're gifted usually, almost always, in terms of music. In fact, 1 in 20 have perfect pitch, as opposed to 1 in 10,000 in the general population. Now, this is the interesting thing, though. Many have this gift of being able to have a conversation that has nothing to do with what they're thinking. But it sounds to all the world like they're right there with you. Some people call this the cocktail party skill, where they can chat, seems like you're really having a conversation, but none of it is anything there that's really on the person's mind. So there's the cool thing about people with Williams syndrome, is that even though they're talking beautifully, you might need to rely more on nonverbal interviewing strategies to get accurate information. Fragile X syndrome. This is a condition that was newly recognized in the early 80s and illustrates to us the trajectory of understanding a genetic developmental syndrome. The first 100 people with Fragile X were described in detail, and every characteristic of those people was thought to be part of Fragile X syndrome. And that is often the early phase of trying to understand a syndrome. In the second phase, there was a lot of effort to try and make Fragile X syndrome a lot like some other syndrome. In fact, many people wanted to say that Fragile X was a subtype of autism. And then now I think we're in the more advanced phase of understanding Fragile X, in that we now can be pretty clear on the characteristics that are absolutely unique to Fragile X, and not just efforts to try and make the person like other people. Characteristics of people with Fragile X, these are the kind of the classic descriptions: tall forehead, low set ears, close set eyes, gaze avoidance. People with Fragile X often find eye contact to be painful. People with Fragile X often have very extra sensitive hearing. People with Fragile X tend to have especially large testicles or unusually shaped ovaries. Their wrists tend to hang lower than they do on other people. Most people, their wrists hang at their hips. People with Fragile X, they hang a little bit lower. And these are the textbook pictures of boys and men with Fragile X. And this is a picture of Steven Seagal, the actor, and I'm pretty sure he has Fragile X. And if you watch the way he walks and runs and moves, and where his wrists are, and the way his face is shaped, and the way his ears are, and all that kind of thing. So I wrote to Steven. I said, I'd like a few tubes of your blood and a picture of your testicles. And he never responded. Go figure. What are some interpersonal characteristics of people with Fragile X? Indirect speech. And it's not an effort to be avoidant or difficult or uncooperative. It's because it's hard. And trying to force people with Fragile X to make eye contact, trying to force them to respond directly to questions, it makes it harder. Sensory integration issues are a huge deal. The hearing, the vision, the skin, all of it. People with Fragile X often are gifted with a stupendous sense of humor. And this is a great way to link up with somebody. And there is an increased risk of certain problems, health problems, for people with Fragile X as they age: heart, endocrine, reproductive, and infectious. So what are some everyday ideas for how to help a person who has Fragile X syndrome. And of course, not all of these things apply to every person. Noise control is a big deal, right? People with Fragile X often do not tolerate abrasive, noisy environments. I am a big fan of shooter's plugs, which is where the person can still hear ordinary volumes. They can hear conversation, but everything's muted, so it's not painful. There's other options people use as well, noise canceling headphones and what have you. Sunglasses inside. One of the reasons that fluorescent lights are especially toxic to people with Fragile X. They cause them to be sick to their stomach, anxious, confused. It's a mess. Many people with Fragile X feel better if they wear tightly fitting gloves or tightly fitting spandex type undergarments, wearing a hat to block out the sun or block out the fluorescent light. I've written many, many hundreds of rocking chair prescriptions. For people with Fragile X, having a rocking chair is required equipment in their home. And they wear them out, usually, and you gotta get more. Rocking chairs are just immensely soothing. Don't know if I know all the reasons why, but I do know it's a thing. Very important to titrate expectations in terms of direct answers. I know a person with Fragile X is getting more comfortable with me when they more frequently answer a question directly. Often you'll sit down with somebody and you'll ask 5 questions and you'll get 1 response that's relevant to the question. As the person relaxes, maybe 1 out of 3 will be relevant to the question. And eventually, if the person really gets relaxed and comfortable, they may be able to respond directly to every question, but it takes a while. And always the question, we can offer these things, but if a person says no, they say no, but the help can be extraordinary. And it is interesting to me how some types of facilities are so resistant to things like getting rid of fluorescent lights. Especially schools, especially special education classrooms. People with autism, people with Fragile X, people with a lot of other conditions get sick under fluorescent lights. Why not just switch them? It's not that hard. Yet the pushback is extreme. Like people resent making that kind of accommodation for that kind of person. It's a shame. People with Down syndrome. As I said, I'm partial to people with Down syndrome who continue to persevere no matter what awful things get said about them or done to them, and have for, of course, forever. One of the biggest mistakes that happened in terms of medical research in people with Down syndrome actually has led to industry-wide disasters. Well, what am I talking about? Basically, there is this idea, and you'll read about it, especially now lately with new meds and so on, that Alzheimer's disease is caused by plaques and tangles in the brain. Plaques and tangles are a change in the nerve cells. They're clumpy little plaques or tangles of extra nerve tissue that's overgrown. And those were observed in some people who died from Alzheimer's disease and were thought to be the diagnostic sign. If you got this, you got Alzheimer's. That was the idea. They never tested the idea, they just went with it. Well, then the next thing that happened was that a whole bunch of people with Down syndrome donated their brains to science. And almost all of them had plaques and tangles, no matter what age they were. So the conclusion was that, well, therefore, everybody with Down syndrome gets Alzheimer's disease. It's a problem, isn't it? Because in fact, plaques and tangles have almost nothing to do with a person's cognitive status. You get plaques, you can have a brain full of plaques and tangles and not have any cognitive loss at all. You can have what looks like a pristine brain and have far advanced dementia. So this is, unfortunately, this misinterpretation of brain data led to fairly atrocious standard care toward people with Down syndrome, which was after the age of 50, a lot of docs thought that they didn't have to do anything. This person, they have Down syndrome, they're 50, they're gonna, if they don't have it already, they're gonna have Alzheimer's, so we're done. Wrong on many levels, right? Wrong on many levels. And this has gotten to be a little bit of, I hate to use the word crusade. Makes me sound so melodramatic. But I do got to admit that I have a really strong feeling about this, because with not that much effort, you can find out whether or not a person with Down syndrome has a dementia that's permanent or a dementia you can reverse and fix. It's not that hard. And because this misinterpreted brain data was having such a disastrous effect on people, some other wonderful researchers rolled into motion right away. They studied people with Down syndrome throughout their lifespans and discovered that only a teeny tiny minority of people with Down syndrome lose cognitive skills. So only a teeny tiny percentage of them might have Alzheimer's. Just didn't matter what the insides of their brains looked like in terms of plaques and tangles. There was another study that proved the same thing, which was, you may remember it, it's called the Nun study. A book was published called Aging with Grace. It was a whole bunch of nuns that donated their brains to science. And they found the same thing. Whether or not one of those nuns had a cognitive loss, a dementia, at the time of their death, it bore little resemblance to what was going on in their brain. If they had a happy, passionate, excited life, they could have a head full of Swiss cheese and still have all of their cognitive faculties intact. Alzheimer's, when it really is present, is an extremely serious disease, obviously. And if I have a patient, I've had patients, of course, who have Alzheimer's disease, a lot can be done to make life for them and the people who care for them better. What I resist is assigning people that status who don't have it. So people with Down syndrome, the most current problem I see is an overdiagnosis of dementia. People with Down syndrome, from a neurophysiologic standpoint, are gifted in terms of intuition. Cognitive decline, if it is observed, is almost always due to things that can be fixed and changed and cognitive function restored. Common medical problems include hormone problems, respiratory problems, inflammatory conditions, digestive problems, sensory problems, and different kinds of seizures as people age. So, is there a quick way to determine whether a person with Down syndrome with cognitive change has developed an Alzheimer's type dementia? Well, yeah, it's kind of a really cool piece of clinical research. I happen to be one of the judges at this research competition. So I got to see exactly what they did. And this has been replicated, of course, a number of times. But I think it's important to mention this particular early, what I think is a hallmark study, because it's old. The data have been out there forever. But it turns out in the few people with Down syndrome who did eventually develop an irreversible dementia, an Alzheimer's type dementia that was true and correct, they developed abnormal frontal reflexes first. Well, what's that? Well, it takes about 98 seconds to check these reflexes in a person. It's a palmomental reflex. If we were in a group, I would demonstrate on some unsuspecting participant, but I'll just demonstrate on myself. The palmomental reflex is where you rub a person's hand, the palm of their hand, and their chin goes like that. That is a positive palmomental reflex, and it is abnormal. That's an indication of frontal release or a tendency or a likelihood of a dementia, unless they've had it their whole life. Other palmomental, you check both palms. That's one. The second one is the root reflex, where you gently touch the person here, and the abnormal response is for the person to turn and latch on, like your finger's a nipple. Do it on both sides. That is an abnormal response. And one of the ways people notice this in everyday life is that, when I help him shave, he tries to eat the razor. It's another way it shows itself. The suck reflex is just like it sounds. You gently touch here, and the person latches on. They're not subtle. If any of those reflexes are present, that is abnormal. The fourth one and the last one is the response to having the sole of the person's foot scratched by the tip of a pen or a reflex hammer. The abnormal response is when the person's big toe goes up. So if that happens, you scratch the bottom of the foot gently and the big toe flies up, that's called Babinski's sign, and that is abnormal. So if any of those abnormal reflexes are present, then the likelihood of an irreversible dementia is a little higher. But none of them mean anything if the person's on a whole crap load of sedating medicine or sick with something. You have to wait till the person has got all those chemicals washed out of their system and what have you. So most of the time, if somebody comes to me and they're tentatively diagnosed with, we think that he's got dementia or Alzheimer's, first thing I do, and it's kind of an interesting way to meet people, can you please take off your shoes and socks? You're not like any shrink I ever met before. I'm kidding. So check all the reflexes. If they're normal, then it's been my clinical experience, and it's borne out by the research data, that they don't have a dementia. They don't have Alzheimer's. If their function is changing, the reason for that change is probably something we can figure out and fix. And restoring all function. Such a nice clinical way to screen people. It doesn't matter. I mean, seriously, if you misdiagnose somebody with Alzheimer's disease, what's the big deal, right? So there was this one fella named David with Down syndrome, 50 years old, 48 years old when I first met him. Say, Ruth, have you ever heard of capgras phenomena? That was an over-the-shoulder question from a case manager who had brought somebody else to come and see me. I said, yeah, delusion of substitutions. Well, I got this guy with capgras, and he's been to 2 neurologists who say that since he has Down syndrome, he's got Alzheimer's, and they also don't know what capgras is. So his parents are a little dismayed. Like, you don't know what this phenomenon is, but you've decided he has Alzheimer's? They're not okay with that. So David came in, and he has 4 sets of parents now. 3 of them are bad. The neurologist said everybody his age with Down syndrome gets dementia, gets Alzheimer's, so that's what's going on. No examination, no testing. Because of the diagnosis of Alzheimer's, he was removed from the home he was living in with 3 other guys who were his best friends since childhood. All 4 of them are very capable, very functional guys, but he had started to slide back, and the people in the house said, well, we can't manage somebody with Alzheimer's, so he lost his home. People at his job said, well, he's a great worker, but he's going to lose it, and we need to replace him, so lost his job, lost all of his activities, heartbroken family. With about this much evaluation, we determined that his cognitive changes were due to depression, which is the most common misdiagnosis, people with Down syndrome, depression causing what's called pseudo-dementia. So he had depression, antiphospholipid antibody syndrome, a chronic viral infection, and a chronic bacterial infection. And the next bit of pushback from his previous treating team was, well, yeah, you can treat all that, I suppose, but is it going to make any difference? You already know the answer, right? We treated all of it, and he was fully 100% restored to his usual level of interaction, functioning, energy, what have you. But his home and his job and a whole lot of his life was gone. Couldn't get it back. All based on a misdiagnosis by somebody who just didn't bother to do the evaluation. We can't have that. We got to keep fighting against that, don't we? And then there's Felicia. Felicia was referred, again, living in a state on the East Coast that's up to their hips in medical schools, right? She's got Down syndrome, and she was referred for evaluation of early onset, rapid onset Alzheimer's. And Ruth, what are you going to do to help us with her quality of life now that she has this early onset, rapid onset Alzheimer's disease? Okay, go to see her, and sure enough, over a period of just a few months, she went from being like the total social butterfly of the whole agency to being barely able to walk, fumbling around, no speech, no interest in doing anything, so sluggish she's barely moving, and just a wreck from head to toe. So it's one of those nice intimate conference settings. I was like in a room and there were 200 people watching this, which was a little funny. But so I sit with her. What's the first thing I do? Check the reflexes, Ruth. So I checked all her reflexes, her frontal reflexes, scratched her feet. She was really nice about it. They were all absent, which means perfectly normal. So what does that tell us? Whatever's caused this change is something that we can fix. Well, we already sent her to an Alzheimer's specialty center, which they had. And the doctors there say, well, this is obvious Alzheimer's, and we're going to give her the best medicine we can for Alzheimer's, which at that time was Haldol. So what evaluation did you do, you super special specialty center? Oh, we didn't need to do any. Well, where does she live now? She lives with her mom. Well, what does her mom say? Well, her mom, we haven't talked to her much lately. Really? Why not? Her mom's a college professor. Her mom's this brilliant college professor type. Well, yeah, but she hasn't been all that responsive. And I'm like, what are you not telling me, right? Well, we invited her today, so she's supposed to be here pretty soon. And this really elegant, beautifully dressed woman stumbles into the consultation. And like she had this like a Chanel jacket, but it was buttoned wrong. And she looked confused. And a couple people were like, man, is she drinking or what's the deal here? Now, Felicia and her mom both have that particularly gorgeous coal black skin that gleams usually, but neither one of them had gleaming, glowing skin. And when you look very closely at them, you notice that the just inside the mouth, just at the rims of their eyes, And in their nail beds, the skin was bright, bright red, like bizarre pink red. And the mom smelled funny. Well, how do you say that? By the way, you look drunk and you smell funny. Not going to say all that, but as you think about it, wait a minute, what is it that causes people to get that cherry red discoloration and can make you very confused, make you very sick, and make you smell like heating oil? Sure enough, their heater at their home was leaking carbon monoxide. They were both being poisoned with carbon monoxide. A new stove cured her Alzheimer's. Now, what if we'd just gone down that rabbit hole, right? Oh, a little Haldol, well, that didn't help. How about a little more? Oh, well, nobody can take care of you in your home like this. And what about her mom? I mean, what about both of them? It was pretty beautiful thing to see what a powerhouse team they were when they were fully recovered. Hyperbaric oxygen, new heater, obviously, and other supports helped them fully recover, and she did very, very well. So important to stay away from the stereotypes and the lazy shortcuts. A couple more things. Phenylketonuria. Anybody remember PKU? We started testing every child born in the United States in 1961 or so. Prior to that, if a person was born with PKU, nobody knew it until they started to show signs of significant intellectual disability. It's another metabolic condition where people don't process certain types of proteins very well, or they don't process them enough. They build up a toxic precursor, and this phenylalanine buildup and often tyrosine depletion damages the brain and all the mucous membranes. So if a person has long-standing untreated PKU, they will not only have enormous difficulties in terms of processing and learning, they will also have a skin that feels like it's crawling inside and out all the time, which leads to all kinds of self-management strategies: clawing, jumping, shrieking, slamming, everything you could imagine. The person's efforts to manage this itching, skin-crawling feeling can easily be misunderstood as neurologically based, but they aren't. It's just pure misery. I was lucky enough back in the dark ages when I went to medical school to work in a PKU clinic with people that had been treated since birth. They were diagnosed properly and treated from birth, and the treatment is a special diet and special supplements. And they could always tell us what their blood phenylalanine level was based on what their mood was like. Because the first thing that gets very miserable in a person with PKU who's not treated is mood, then thinking, then all the skin surfaces of the body. So, controversy from a few years ago. People used to say, if you don't treat people with PKU as children, there's no reason to bother in adulthood. It's like the damage is done, there's nothing else you can do. And to prove that, they did a few studies where people were put on the proper phenylalanine diet, PKU diet, phenyl-free, tyrosine supplementation, what have you, for a period of 6 weeks, which is supposed to be enough to help repair or adjust neurotransmitter issues. Why didn't it work? Because that's not all that's got to heal. People with PKU who've been untreated for a long time not only have to have their neurotransmitters adjusted and corrected, they need to heal every piece of skin and mucous membrane in their entire body. How long does that take? More than 6 weeks. So some better studies were done where people were on the PKU plan for a minimum of 6 months. And those studies showed stupendous improvement. So it turns out that at any point in a person's life, if they have PKU, their quality of life will improve with proper treatment, proper management with the PKU diet. Some get, well, isn't that terribly restrictive? Isn't that, what's the sneaky fix to try and make a restrictive diet not such an aversive thing? Well, I'm not saying it's the right answer, but what we did was we went to a bunch of culinary schools, got these chef students, and got it so that they could get extra credit or bonus credit or something, elective credit, for creating stupendous PKU diet compliant meals, so that the guy with PKU ended up eating better than anybody else he knew. There's a way around it once we decide to do it. Improvement requires not just neurotransmitter adjustments, but healing of every skin surface in and outside the body. Velocardiofacial syndrome is a midline condition, and originally it was felt to be one of the genetic markers for schizophrenia because so many people with velocardiofacial syndrome have schizophrenia. That may or may not be an association. It's a midline condition, and interesting to me is that although people usually notice the schizophrenia in people with velocardiofacial syndrome, it's sometimes a little bit longer before people notice everything else. And the everything else has to do with how well they can recover from schizophrenia. So repairing the cleft palate, repairing the cardiac abnormalities, repairing the different kinds of endocrine issues having to do with midline endocrine structures like the thyroid. This is a picture, as you can see, people with velocardiofacial syndrome. It's not a particularly dramatic syndrome. The long distance between the space below the eyes and the side of the mouth, it's longer in people with velocardiofacial syndrome as compared to the general population. But that happens in a lot of people, so that's not really lights and sirens diagnostic. In addition to schizophrenia, here's some more pictures of people with velocardiofacial syndrome. People with this condition typically have strong aptitudes for music and computers. They often have stronger reading and spelling than math. It's not that they're not trying, it's just harder. They have some similarities interpersonally with nonverbal learning disability, which is people that have a little bit of trouble or more than a little bit of trouble with navigation, even though cognitively they're very apt in other ways. They often have had some fairly big surgical procedures, big scary ones like heart operations and palate operations, and they can have some residual anxiety and trauma from that. There's a abnormality in physiology, catecholamine O-methyltransferase deficiency or deactivation, increases catecholamines. Now, what does all that mean, Ruth? That means that when a person is triggered, it's much harder for them to resolve an episode of severe anxiety or panic. They just need more support and a little more time to do it because the enzyme that'll shut off that rush of chemicals is in much short supply. They tend to have more seizures than other people, and they can be misdiagnosed as having impaired communication neurologically, when in fact it's more likely to be a muscular issue that interferes with spoken communication if present. Really, really a good idea to avoid stimulant medicines. They just compound the problem of the COMT deficiency. Considering certain supplements may help and anti-epileptic medications may be more potent for the anxiety issues if they're present. So that is like a whirlwind tour through a few issues of a few different syndromes. There's lots and lots written about each one of these syndromes. And what I hope to do as we go through these kind of snack-sized portions of information is to kind of stir up curiosity. You know, what I've written here, maybe it's out of date. Maybe it isn't. Maybe there's something even more revolutionary. But I hope you'll be interested in knowing more and more as you discover the presence of these conditions in the people that you support. And I want to end with emphasizing a point that we started out with, which is that the sky's the limit. These two people, they were big heroes in Colorado. I lived there for a long time. They loved going to seminars put on by so-called experts in people with Down syndrome. They loved going to those seminars and hearing about how people with Down syndrome can only achieve so much academically, and people with Down syndrome are always sterile, and people with Down syndrome cannot blah, blah, blah. And they'd love to raise their hands and say, so, does that mean we have to give back our college diplomas and our children? Always, always close touch with the people who have these conditions that are willing to share about them, because they'll have the most advanced information and they'll keep us from those inappropriately low expectations. Thank you so much for attending.